Good afternoon, everyone, and welcome to our March series of broadcasts for the future of vascular health. This month, we'll be focused on kidneys, since March is traditionally Kidney Awareness Month. So it's my pleasure to have as my guest again today, Dr. Hans Vink. He's the Chief Science Officer for the Glycocalyx Research Institute and Glycocheck. And so, as I mentioned at the start, we're going to focus on kidney disease. And to start out with, I really wanted to talk about the statistics. I think kidney disease is one of those things that people have heard of, but unless you have it, or unless someone you love and care about has it, it's not high on your radar. So I wanted to make people aware of, first of all, what the statistics look like. So when I first started working on this project about 15 years ago with Hans, the statistics that I was familiar with was that about 1 in 9 people in the United States had chronic kidney disease. And so as I look at the latest statistics, as they progressed over the last 12 to 15 years, they're now estimating that 1 in 7 US adults have chronic kidney disease, and that's about 35 million Americans. So, and it's even higher as you look at different classes of individuals and their risk factors. So, for example, 1 in 3 people with diabetes have chronic kidney disease. 1 in 5 people with high blood pressure have chronic kidney disease. And so other important risk factors that we know about would be heart disease. We talked a little bit last month as we talked about the progression of heart disease, how that becomes interrelated with your kidneys and affects them. And then we also find there's a big relevance or evidence that shows that family history or ethnicity has a big effect on kidney failure. And so the striking thing is as many as 9 in 10 adults with chronic kidney disease aren't even aware that they have it. And so we're going to talk about that today and talk about how's that even possible that many people could be walking around on the street every day and not even know they've got this. And so chronic kidney disease gets progressive, and we'll talk about that today. And we'll talk about the stages, and Hans is going to go into the detail and correlate actually how that progresses and how it's related to the breakdown of your glycocalyx, and how, kidney failure, strokes, heart attacks, how all of these things are progressive and how they all end up being interrelated. And so the thing is, 2 in 1,000 Americans are living with end-stage kidney disease. And what that really means is that their life expectancy, mortality rate have significantly increased, and it's a big economic toll. And we're going to talk more about that here on the next slide. So a little bit more about the statistics. So chronic kidney disease is more common in women, about 14% of women, and about 12% in men. As I mentioned earlier, ethnicity is an important factor. Black adults, about 20% of the population have chronic kidney disease. White adults, it's about 12%. Hispanic and Asian adults, it's about 14%. So the genetics that you were born with do have a big impact on your potential to develop chronic kidney disease. So it's most common in people that are above 65. Well, that would make sense because they've been around a long time, and so now their kidneys have had a chance to progress in the cycle that we're going to describe to you today. But we're even seeing ages 45 to 64, it's 12% of our population. So if you look at 330 million Americans, that's a big number. 18 to 44, it's still 6%. So the alarming thing is that we're seeing increases in all of the populations in America. And it's not just America, it's in all countries of the world. Next slide, please, Hans. So when we talk about end-stage kidney statistics, so that's the people that are stage 5, and we'll describe what that is today in more detail. But you know, that's just under 1 million people in the United States that have end-stage chronic kidney disease, and 68% of those are on dialysis, and 32% have had a kidney transplant. And so a lot of people don't really understand the impact of dialysis. I've come to understand the real statistics on dialysis. What a lot of people don't understand is the real financial toll and the health toll that happens to people in terms of lost productivity when they're on dialysis. So for example, those people that are on dialysis, you know, that takes up a big chunk of their time. If they don't do home dialysis, that means someone has to transport them to a dialysis center. When they finish the dialysis, they typically leave. They're pretty run down. They don't feel good for a day. So quite often during the week, they don't feel good. And so it affects not only their ability to be productive, but it ends up affecting their family because the caretaker becomes less productive also. So males are 1.6 times more likely to develop end-stage chronic disease than females. Black people are 4 times more likely to develop end-stage kidney disease than white people. And then Hispanic and Native American people are more than 2 times likely. And so this is a striking statistic. The number of Hispanic, Native Hawaiian, and Asian people with kidney failure has tripled since 2001. So this is clearly an epidemic that's silently happening in our country that we really need to understand more about. So in 2023, 27,332 kidney transplants were completed. As of November last year, 2024, there were over 90,000 people waiting on a kidney transplant list to get a new kidney, hopeful that they would be able to get one. 46% of those people that have been waitlisted or waiting for a kidney have received one in the last 5 years. So what that tells us is if you're on the waiting list, it can take time to find the right donor match and for everything to line up perfectly for you to be able to get that kidney transplant. And so another important factor is children are 85% more likely to get a transplant than adults, as you can see on the slide. And that's probably because one of the things they're looking at is potential life expectancy. All those things go into the waiting factor to determine who's going to be able to get a kidney. So let's look at the economic impact of kidney disease. Medicare spent $77 billion in 2021 on chronic kidney disease, and that's not including end-stage kidney disease. So if you look at the annual per person Medicare spending, and this is in 2021, so it's not updated, you know, it's 4 years old, so we know it's only gone higher. The average spending is $28,162 a year on chronic kidney disease patients versus $13,000, over double of the cost of Medicare, and the money that's spent is on chronic kidney disease. And then if you look at the amount of money that was spent on end-stage chronic kidney disease, in addition to the people just with chronic kidney disease, that was over $52 billion. So we're talking about very large sums of money, and it's costing our society to treat and help these people prolong their lifetimes. So chronic kidney disease patients have twice the mortality rate of non-kidney or chronic kidney disease patients. Mortality rates continue to increase, they're not going down for end-stage kidney disease patients. And patients that are able to get a kidney have a significantly lower mortality rate than those that are still on dialysis. And so what a lot of people don't understand is the average life expectancy for someone on dialysis is less than 7 years. And so, so by comparison, it's a big problem in our country. So with that, now we look at, what the real hard numbers are in the statistics. This month, what I want to dive into over the next 4 weeks, you probably have seen what our schedule is going to be this week. We're going to go into kidney disease specifically. We want to understand the kidneys, how they work, and then what causes your kidneys to break down, and how does kidney disease develop, and what are the stages of kidney disease? How is that measured? And what's actually happening in your body as your kidneys begin to fail. So I'm going to turn this over to Hans, and we'll now go into this discussion for this week.
Well, thank you, Bob. And before I'll start to discuss the role of glycocalyx damage in causing kidney disease, I just want to explain this slide a little bit more, explaining how important the kidneys are for our health in controlling blood pressure and in controlling urine formation. So on the right hand side, here's a box where it says kidneys. And the way the kidneys sense that blood pressure might getting too low is that with lower blood pressures, there's less blood flowing through the kidneys and less filtration products formed by the kidney. And when that happens, the kidneys start triggering production of a hormone called renin. So the renin, the RAS system that mentioned on top is the renin, angiotensin, aldosterone system. And how they're all related, I'll explain here in a minute. So when blood flow goes down in the kidney, renin is secreted, and renin triggers the conversion of two other hormones, angiotensinogen into angiotensin 1. And then by another enzyme that's mostly present in the lung called angiotensin converting enzyme, angiotensin 1 is converted into angiotensin 2. So angiotensin 2 has several functions. So when blood pressure is low and there's a low filling of your cardiovascular system, then angiotensin 2, when it's formed, triggers your brain to make you feel thirsty. So you're thirsty, start drinking more fluids, and those fluids will end up in your vascular system, fill up your vascular system, and increase your blood pressure in that way. Another way that angiotensin would increase blood pressure is by stimulating the adrenal gland to produce more aldosterone. And aldosterone acts on the kidney function by reabsorbing more water back into the cardiovascular system, and thereby causing more blood volume and increasing blood pressure. And the third function of angiotensin is that it acts as a vasoconstrictor on your arterial blood vessels. And it's one of the other presentations that we had on our cardiovascular system. When arterioles and arteries constrict, the total systemic vascular resistance goes up, and that will also increase your blood pressure. So those are all important functions of the kidney, different ways by the kidney control blood volume and blood pressure, in addition to controlling the amount of urine that's produced by the kidneys. So there's different ways by which glycocalyx damage can affect kidney function. And the first way I want to discuss with you is on large arteries and atherosclerosis. Like in one of our previous presentations on atherosclerosis, we've shown that atherosclerosis happens in the large arteries, causes an occlusion of the artery that fuses a different organ, and that occlusion of the artery can cause low blood flow supply to that organ and cause organ damage. So one of the arteries is the renal artery. So here you can see in the middle you have the big aorta, they're taking the blood from the heart, and then it branches off in these renal arteries, perfusing blood to the kidneys. And again, at these branching points, like we earlier discussed, you can have atherosclerosis. shown here. So a little bit downstream of that branching point where the renal artery branches off of the aorta. Because of the complex blood flow profiles at that branching site, we have sites of very thin glycocalyx. And you might remember from our previous presentations that glycocalyx is a very important protective compartment on the inner surface of your blood vessels. And when you have a very thin glycocalyx at these branching points, then these sites become highly vulnerable for damage. They start leaking cholesterol into the vessel wall. Immune cells will also migrate into the vessel wall. Blood platelets will stick to the surface of the blood vessels, causing blood clots. So this will trigger the start of atherosclerosis, and which leads to narrowing, in this case, of the artery that takes blood to your kidneys. So when that happens, and this is an image showing an occlusion of your renal artery. So this is the aorta. These are your renal arteries, and this by injected contrast fluid into the blood vessels. And the lack of contrast fluid over here, where the arrow is, demonstrate an occlusion of the blood vessels. The lumen of the blood vessel gets very narrow, and that causes a lot of resistance. And because of that lot of resistance, there's very little perfusion of blood into the kidney, and that tricks the kidney into thinking that blood pressure must be low because there's very low blood flowing into the kidney. That triggers that renin, angiotensin, aldosterone system that we just discussed. That will cause an increase in the resistance of all your blood vessels in all your body because of the release of angiotensin, and will an increase in your blood volume because of your increased thirst and increased retention of water by aldosterone. So the increased resistance and increased blood volume will result in an increase in blood pressure, causing hypertension, because blood pressure wasn't really low, but the kidney thinks blood pressure is low because of poor kidney perfusion. So in our other presentation that we did a few weeks ago on hypertension, it shows that this part, the renovascular part, by occlusion of a renal artery, contributes to about 4 to 5% of the cases of hypertension. Well, another way that a damaged glycocalyx can affect kidney function is by damaging your microvasculature. So we know now that every organ has very many small capillaries providing oxygen and nutrients to all the different tissue cells in every organ, and the same holds true for kidney function. So when glycocalyx is damaged, you will start losing many of these. So another way in which a damaged glycocalyx will affect kidney function is by damaging the smaller vessels, the blood capillaries. So we discussed previously that at the organ level, there's many capillaries that take oxygen and nutrients to individual cells in your organs. And when you start damaging your glycocalyx, you lose a lot of those capillaries, which will result in damage to also to the kidney. So this again shows what happens when your glycocalyx is damaged. You see that as soon as glycocalyx gets damaged, and this is an acute challenge of your systemic glycocalyx, that you lose already 40 to 50%. Damage your glycocalyx, and this is an example of an acute systemic challenge of your glycocalyx, for example, as a result of a systemic infection. As soon as glycocalyx is damaged, you lose about 40 to 50% of your capillaries that facilitate blood flow into the organs. We have seen similar reductions more chronically in people at risk for cardiovascular complications, like we discussed in the NEO cohort. So people with higher cardiovascular risk factors because of their age, or because of their smoking, or their level of obesity, or their poor control of their diabetes. As soon as you start damaging your glycocalyx, you will start losing many of your capillaries, and you start losing 30, 40, 50% of your capillaries, which at some point will cause organ dysfunction and impaired kidney function. And one way that loss of capillaries affects kidney function is shown in this slide. This shows a little bit more details about the structure of the filtration unit called the nephron in the kidney. So on the left-hand side, again, you have the renal artery that we discussed previously, taking blood into the kidney. And first, when it enters the kidney, that blood will flow into what we call the filtration unit, or the glomerulus. So actually, it's a collection of capillaries where a lot of filtration happens and where the urine is produced. And then the blood flows out of that glomerular unit, still with a lot of oxygen, because there's no oxygen lost at this part of the capillary network. Then the capillaries, blood flows through remaining capillaries that perfuse the rest of the kidney. The rest of the kidney consists of what we call tubules. So the urine is formed here in the early part in the glomerulus. Then the fluid that's filtered flows through these tubes down and up again, and ultimately urine is produced. But all these tubes need a lot of oxygen to stay functional and not to get damaged. So the capillaries that leave the glomerular unit flow down to provide nutrients and oxygen to those tubes. And when you start losing capillaries at the onset of glycocalyx damage, then you will lose many of these capillaries that provide oxygen to these tubes. And the tubes need oxygen all the time because they're very busy filtering a lot of the ions and controlling your water balance. And as soon as you damage these capillaries and you lose these capillaries, these tubes will be damaged and develop what we call tubular necrosis. So these tubes will die, and that will greatly impair your ability to produce urine, and that will impair your kidney function.
So, question for you there, Hans. One of the things I've noticed over the last years as I've tested hundreds of people with the GlycoCheck is that there seems to be a correlation with the number of capillaries, true capillaries, 4, 5, and 6 microns, in people with low numbers of capillaries and a high PBR score, meaning that they have damage to their glycocalyx, that it contributes to a low score. And so when I've asked people about their health and different things, they don't know what's causing it. And then I'll just say, how are your kidneys? And then I'll make the recommendation next time you go into your doctor and get a physical, maybe just ask your doctor to take extra care and make an assessment of your kidneys. And quite often, because of that early assessment we did with the GlycoCheck, we find people that are going to be in the later stages of chronic kidney disease, and they didn't even realize it because this was happening silently behind the scenes.
Yeah, and that's exactly what happens also in the kidney, Bob. So if you start losing a lot of your capillaries systemically and as measured by the GlycoCheck system sublingually, it also means in other organs like the kidney, you will have fewer and fewer capillaries. And the thing with the kidney is that you have many of these nephrons. So you have thousands or even millions individual nephrons. So when you start losing a few of those nephrons, when you start damaging your capillaries, initially you won't notice any loss of kidney function. There will still be enough filtration capacity in the remaining nephrons, so it takes a long time to detect impaired kidney function after you already start damaging a lot of your nephrons. And I'll get back to that a little bit later when I go in more detail over the filtration capacity. So the filtration really happens at this part of the kidney in the glomeruli capillaries, and I'll get to that a little bit more detail in 1 or 2 slides. So this slide again illustrates your 2 sets of capillaries that you have in the kidney. First, when the blood comes in, the first sets of capillaries is where filtration of water and toxins takes place. So the water and toxins leak out of these highly permeable glomeruli capillaries. The fluid is collected in the beginning of your urine compartment called the Bowman's space, or the Bowman's compartment, and then that fluid starts traveling through those tubules that we discussed before. And then the second set of capillaries is when that oxygenated blood leaves your glomeruli capillaries, travels to the rest of the vasculature in the kidney, and then you have your peritubular capillaries. So those are the capillaries close to the tubules itself, bringing the oxygen. So the red color is oxygenated blood, and those capillaries take the oxygen to the tubules, make sure the tubules stay functioning and healthy, and then the oxygen deprived blood is collected in the kidney veins and circulated back to the heart. But when you start losing capillaries, and especially these capillaries, will cause damage to your tubules and blocking the tubules and impairing urine production. Also, what I want to focus next is a damaged glycocalyx will affect that filtration unit. And the way it affects that filtration unit is illustrated in the next few slides. Again, this is a more detailed picture of that glomerulus, that filtration unit of the kidney. Blood flows into the filtration unit, branches into these glomeruli capillaries. Water and toxins are filtered through the wall of these capillaries into the Bowman's space and entering the renal tubules and on its way to form urine. And then traveling through those glomerular capillaries, the blood ultimately will leave the glomeruli and then on its way to the peritubular capillaries. Now, when we zoom in on the endothelium that lines these glomeruli capillaries, get a picture on the right-hand side. So on top would be where the blood is flowing in these glomeruli capillaries. These cells here are the endothelial cells lining the capillaries of the glomerulus. And one thing that is remarkable of these glomeruli capillaries, where a lot of the filtration happens, is this is a specialized type of endothelium called fenestrated endothelium. Fenestrated means there's little openings or windows, big holes actually, in the endothelium that allows a lot of the fluid to be filtered over the surface of the glomeruli capillaries. Just to give you some sense on how much fluid is filtered over these capillaries every day. So if you look at a normal kidney function, a perfectly healthy kidney, it has a filtration rate, or glomerular filtration rate, or GFR, of approximately 120 milliliters per minute. Well, that happens every minute, 120 milliliters. So that's a huge amount of fluid filtered. So if you multiply that times 60 minutes in an hour, it's about 7 liters of fluid filtered over these capillaries every hour. And then per day, it adds up to about 170 liters per day that's filtered over these glomeruli capillaries. Now, you might think that's a lot of fluid. We don't even have that much fluid in our blood compartment. We only have 5 liters of blood circulating, of which is only 3 liters is plasma, so the fluid that's being filtered. And that's because more than 99% of all the fluid that's filtered over the filtration barrier in the glomerular capillaries reabsorbs in your tubules. And only a small part of it is used to produce urine. So you lose only, let's say, I don't know, a liter or so per day in urine. So you have to drink to refill that. But most of the filtered fluid is reabsorbed. But that's why that happens in these capillaries, because of the big holes in the endothelium. What's actually remarkable is that although a lot of fluid is filtered, other bigger molecules like albumin, the protein albumin that's circulating in blood, is important to maintain your fluid balance, isn't filtered over these big holes. And for a long time, people didn't understand why albumin doesn't leak with fluid over these big holes in the endothelium. Because to give you some perspective, the size of these holes, these fenestrae, is approximately 40 to 100 nanometers, which is huge compared to the size of an individual albumin molecule, which is only about 6 nanometers in diameter. So these big holes are 10 to 20 times bigger than the size of albumin. And still, no albumin apparently leaks over the endothelium in those glomerular capillaries if you're healthy. And it turns out that's not happening because all these holes are filled with glycocalyx. Like any other endothelium in the rest of your organs, different organs, on the surface of the glomerular capillary endothelium is a big dense network of glycocalyx polysaccharides that binds a lot of proteins and sucks in a lot of fluid, forming a very stable mesh. And actually these holes are not open but filled with glycocalyx also, which prevents the albumin from leaking. And that turns out to be crucial to keep your kidney healthy. In the next slide, I'll give you a little bit more context. Again, it shows you the same cartoon. The big arrows are representing fluid leaking through the fenestrae in the highly permeable endothelium, but no albumin leaves the vascular space, or no albumin travels with the fluid, and no albumin gets into the Bowman's capsule or the urinary compartment. One thing you will notice if your kidney functions start being compromised, that your urine might look a little bit foamy. And when you let your urine checked by your physician, they also will measure the albumin content or your protein content in the urine. And that's happening when your glycocalyx start being damaged in your kidney capillary. So that's a first sign, early sign, that your kidney capillary endothelial glycocalyx is damaged and you start losing albumin over your endothelium, ending up in the urine. Now, why does that trigger further damage to your kidney? That's shown in these images. So next to the cartoon is a real image of a kidney glomeruli capillary stained for glycocalyx. So on top would be where the blood is flowing. This is the endothelium, this is the basement membrane, and these are the podocyte cells that line the surface of the urine compartment. Now, when you pay attention, you see these black dots here in the endothelium, and these black dots are actually very dense concentration of glycocalyx that fill up the holes of the fenestrae. So those holes are highly permeable for water, but because of the high content of glycocalyx in these holes, there's hardly any protein that leaks across the endothelium. Now, when your glycocalyx is damaged, for instance, in people with diabetes, then glycocalyx will not be filling these holes. So in the middle panel, after damage of glycocalyx, in this case, experimentally we used hyaluronidase to damage your glycocalyx. Now you see that there are very translucent openings in the endothelium. So these are the fenestrae without any glycocalyx presence. Now they become highly permeable. And then in the third image, we also stained for individual albumin molecules if they ended up leaking over the endothelium, getting close to those podocytes that line the inner lumen of the Bowman's capsule. And here you see the individual little black spots on the surface of podocytes, showing that indeed when glycocalyx is damaged, not only fluid leaks, but also the plasma proteins start leaking, attaching to the surface of these podocytes, and that triggers a process that makes these podocytes sick. They get damaged, and when they get damaged, they contract and they detach from the outer surface of the capillaries, and that triggers a wound repair process. A lot of fibrosis will start developing, scar tissue will be formed on the outside of these capillaries, and when there's too much scar tissue, these capillaries will lose function, will not longer be able to contribute to the filtration function of the kidney, and kidney filtration function will go down. So your GFR values will go down if you start losing a lot of these filtration capillaries. Well, to illustrate that process, I also want to show you an animation of how leakage of albumin through damaged capillaries in the kidney results in damage to your podocytes, and how that will result in fibrosis of your glomeruli, filtration units, and loss of kidney function. So the animation is in Dutch, but I will talk you through the animation so you'll understand what's happening. So this is a movie about the development of kidney damage in diabetes. Here you see the blood flowing into the kidney in glomerular units and flowing out of the kidney again, and filtration fluid formed in the Bowman's capsule. Here's one of those filtration units, blood flowing into a glomerular capillary, being filtered with toxins leaving into the urine compartment. And you see the podocytes on the outside of these capillaries are highly tightly connected, all their fingers intertwined, causing very narrow barriers that only small toxins can leak through. On the inside, you see that there's a glycocalyx covering the endothelium, and only small toxins can pass through glycocalyx, while big proteins like albumin bounce off of glycocalyx and don't get close to the endothelium. And when glycocalyx is damaged, like in diabetes, these big openings of the endothelium in those glomerular capillaries become accessible for the proteins. They start leaking through the holes, and on the outside, those proteins will attach to the podocytes. The podocytes will contract, remove themselves from the outside of the kidney capillaries, and the kidney capillaries become highly exposed and naked and very vulnerable. And to repair that damage, there will be some scar tissue formation to initially try to cover up the outside of the capillaries again. But when there's excessive scar tissue formation, it will completely engulf those filtration units, and they will just die off and become dysfunctional. And step by step, by losing more of these filtration units, you will start losing a lot of your filtration capacity. Now, when that happens, you will start losing filtration capacity. So the more of these filtration units are damaged by scar tissue formation after you start leaking albumin over your endothelium, more and more of these units will start disappear, and instead of your optimal 120 milliliters per minute filtration capacity, it will go down over time. And the levels of decrease of that filtration capacity, so the lower values of that, what we call glomerular filtration rate, also determines what level of kidney failure you will have. So initially, you still have a relatively okay level of filtration capacity, like 90 milliliters per minute or more, but because of the increased levels of albumin leakage into your urine, you will detect early stages of kidney failure and will be classified as stage 1. When you start losing more of your filtration capacity, so when you have less than 90 milliliters per minute filtration capacity between 60 and 90, you will be classified as stage 2. When you have reduced filtration capacity between 30 to 60 mils per minute, you will be classified as stage 3. Less than 30 up to 15, stage 4, and when you have less than 15, you are classified as very severe or end-stage kidney failure, as Bob discussed before, and you really need kidney function replacement therapy, either by dialysis or get a transplant to regain more of your kidney function.
Thanks, Han. This is really fascinating. If you could stay on that last slide for just 1 second. So I think this is really fascinating for our audience, because as they go and have their physicals and get their results and they look at the printout, the things that are associated with kidney health obviously are GFR. So will you describe that one more time just so people understand what GFR is?
Yeah, GFR is your glomerular filtration rate. So if you look at one of those filtration units, it's highly permeable and blood flows through at a relatively high blood pressure, pushes the fluid through those holes in your endothelium, and that forms filtrate in the Bowman's capsule. And that filtrate, you take all the toxins out and you reabsorb the fluid later. But really you need that high level of filtration rate to have enough toxins being cleared from your body at all times. One of the waste products that's being filtered and that's being used to monitor whether the filtration capacity is still intact is a waste product called creatinine. So creatinine is a breakdown product that circulates in the blood. It's filtered by the kidney into the urine. And one way to monitor your kidney function is by check your blood levels of creatinine. So if your kidney function is okay, your blood levels of creatinine should be very low, because everything is filtered in the kidney, ending up in the urine. When your blood creatinine levels start increasing, that's a clear sign that you have an impaired filtration capacity of your kidney. Well, the problem only is it takes a long time for blood creatinine levels to increase, because in early stages, the initial loss of your filtration capacity can be compensated for by other parts of your kidney that can still clear your creatinine out of the blood. So by the time you see significant increases in blood levels of creatinine, you've already lost like 60 or 70% or more of your kidney function, and you're down to kidney failure stage 3 or 4 before you even realize that your function of your kidney is declining, because it's so difficult to detect these increased levels of creatinine.
So I think that's really helpful for our audience. So basically, that progression that you just described is really kind of happening silently, and it's not even really detected to any degree until people are in stage 3 or 4. And that's why so often when we pick up people on their microvascular health score and we look at their capillary function, it's not even on their radar or their doctor's radar, because all of this has been happening over several years. And then suddenly we're identifying you've got really low capillary function. And so that's been happening silently. And all of this potentially has been progressing in your kidneys. Is that accurate?
That's completely accurate, Bob. So like other organs, also the kidney function will decline when capillary density goes down. And we showed in other studies that we can pick up loss of capillaries years before diseases will present themselves. And people at risk for these complications can lose up to 50% of the capillaries years before organ function clinically will decline. So yeah, by monitoring the glycocalyx damage and your loss of your capillaries, it gives you an early indicator that something might be happening to your different organs, and will trigger you, hopefully, to pay more attention to organ function and identify loss or early loss of kidney function at an earlier stage.
Well, thank you, Hans. This whole discussion, this whole journey we've been on the last many years, and studies that we've been in for many years that have been funded by government entities, we're going to go into those in our coming discussions in the upcoming weeks. And so there's a real interest in governments, especially, to figure out how do they slow the flow of the dollars that are being spent, because these are all progressive chronic diseases that basically linger a long time and are very expensive and rob productivity from society. So it's really important that we understand this and figure out what we can do about it. And that's what we'll be discussing in the upcoming weeks. So next week, I think you're going to really want to be tuned in. We'll have some special guests that we've had the pleasure of monitoring their progress over, I think, about the last 10 years. Went from one of those chronic end-stage kidney disease patients, been on dialysis for, I think, 3 times as long as is normal, to then being able to restore their vascular and microvascular system to a point where they just were able to have a kidney transplant, which is totally unheard of. And it's going to be a fascinating story to listen to this next week as we talk to our guests. It's an actual example that basically, I guess, gives, a pretty good 1 in 7 people, it gives them hope that there's something that we can do about this. So I'm looking forward to that call next week, and we'll see you next time on the Future of Vascular Health. Thanks for joining us.
Thanks for listening to the Future of Vascular Health. Healthy vessels, healthy future. If you're ready to take charge of your health, it's time to check out Revasca. This powerful supplement is designed to protect your glycocalyx, the microscopic layer that keeps your blood vessels healthy and strong. Revasca can help support your heart health, improve circulation, and even reduce high blood pressure. It's also great for boosting brain function, keeping your kidneys healthy, and preventing vascular complications before they start. Think of it as a way to keep your body running smoothly so you can live longer, feel sharper, and stay active. Don't wait. Take the first step toward better health today. Visit glycocalyx.com to learn more about Revasca and how it can help you protect your future.